So we're going to talk about anterior to posterior mobilization in the cervical spine, a mobilization that is not common unless you've been exposed to the functional manual therapy approach. I honestly don't know of many other approaches that mobilize cervical and lumbar spine anterior to posterior, which I think is pretty cool, but also effective and needed in my biased opinion. So anterior to posterior, as we talked about progression, mid-lower cervical, we want to do an AP first typically. Upper cervical, typically we do it after we do the shear mobilization, so it's done second, okay? It's the same anywhere throughout the cervical spine. It's easier to access mid-cervical, and oftentimes mid-cervical ends up being what needs an AP most, but I mobilize a lot of C1, C2 in the upper cervical. It's just a little trickier to get on up there, so maybe I'll kind of show that as well in this video. Now, to get anterior to posterior, you can mobilize anterior to posterior. Actually, I should get this. Let's slide to the left just a little bit, Kelsey. You can mobilize anterior to posterior more unilaterally, which would ultimately be a relative rotation, right? So if I'm on the right side and this is prominent, then you could say that I am not just working on an anterior kind of translation or trying to get it to translate posteriorly, but actually if I'm more unilateral, I'm working on a relative right rotation if the infield is harder on that right side, okay? So you can do that if that's what the client needs. The purpose of this mobilization, though, is to get as central as you can to get a more true central AP to the vertebral body, basically, so that the whole kind of cervical spine will be able to sit in a better position over the base of support, which is the thoracic girdle and thorax, okay? So I just wanted to mention that because most of the time people will try to do an AP and it'll just be unilateral. That's more of a rotational mobilization there, okay? So in order to get more central, we kind of have to move the thyroid cartilage and the cricoid cartilage kind of away or out of the way so that then we can sink in onto the bodies there, okay? Other things that I want to say here is you have your mandible that comes and kind of gets in the way of some of the upper cervical. So a lot of times with getting on C1, C2, even potentially, maybe more so just C1, C2, you kind of have to have your patient, you kind of have to like tilt their chin up a little bit, get that access point to C1, and then try and bring them back towards a neutral position. Sometimes they can't even get to that neutral position. That's the problem, why you want to do an AP, but you still have to kind of tilt them back to work back towards a more neutral position. So if I bring this back on the floor, so with Kelsey here, I have her thyroid cartilage, cricoid cartilage here, and I am just going to kind of slide it out of the way. When you first start doing this, you might actually want to slide it out of the way. As time goes on, you can kind of slide it out of the way with your treatment hand where you're just kind of shifting it over, where you just kind of, let me back up. Anytime you're working on this part of someone's cervical spine and you're working into a vulnerable position, really anywhere in the body, but for this in general, you're working into a vulnerable position with your hands that could reproduce some memory of choking or strangulation that they've had, or it's just a vulnerable position and they don't feel that comfortable with you working there. You must ask for consent to work in this area. So is it okay if I work on the front of your neck? Mm-hmm. So again, you may initially want to kind of move that out of the way so that then you can access the more centrally onto the cervical spine. I typically will just kind of sink to the layer of that thyroid cricoid cartilage and then shift it over before I then continue onto my descent. That's a weird word. onto the cervical spine, right? So now I'm onto the front of the cervical spine, and I can actually maintain my depth and feel what level am I most interested in mobilizing, okay? The hardest infill for me is right here. Kelsey could probably confirm that. And then from here, I could have her, I'm sinking in to get the infill that I'm looking for. And then I could have her just nod her chin down. Good, and let that go. Good. And I can even localize a little bit through my hand. What I am actually interested in feeling this is I actually want to have my assisting hand underneath her head. This starts her out in a little bit more of a neutral position. And I just feel like in order to help that move in the anterior to posterior direction, I actually want to use cervical flexion to do that. So again, I sink to the level of the thyroid cartilage, I push it out of the way, and then I sink down onto the front of her cervical spine. And right here, I have a hard infill. And then I'm bringing her neck into flexion. I engage that infill further there. Now I just want to see if I take it a little bit to the right versus a little bit to the left, what winds that up a bit more. And it's actually flexion with a little bit of a right rotation there. And now from here, I could say just breathe in and breathe out. Good, and I'm trying to take up any slack that I can there. I could also say, don't let me lift your head up any further. Good, and let it go. Good. And again, don't let me lift up. Breathe in there and out. And with my treatment hand, I'm just staying on that infill. Can be tender for people. Oftentimes it's not like terribly tender. They'll let you do it, but definitely want to, give people the option that if it's too tender, let me know. I'll go easier, or we can just try to do the same thing in a different way. But this is anterior to posterior mid-cervical. Now let me just show real briefly how I get on the upper cervical. So I will use my assisting hand underneath the cranium. I will kind of tilt the cranium up in order to get on that upper cervical. Now, if I try to sink straight in at the level of C1, there's a lot of myofascial tightness that's pulling from her jaw area that is not going to allow me to get there. So I actually start below, and there's a lot of, typically the skin was happy to go up that way. So I'll start below, and then I will actually kind of sink some of that soft tissue up versus starting on and trying to sink down. There's just like, you feel that big pull coming up through your jaw. So I'll just kind of sink up into C1 and find an infill that I'm interested in. And sometimes I have her rotated away, so I might actually have to bring her back to neutral to get on that infill right there. And now I'm bringing her back to neutral. And I actually can get her to neutral, but that's right where that hard infill starts. And then I could have her just nod down just a little bit right there, and that further engages it, and let it go. I could couple the nod with breathing. I could also, once I feel like I get her to a good flex position, then I could actually pin her C1 or C2 down towards the table and have her kind of lift away to get it just a more aggressive mobilization in the anterior to posterior direction. Okay, so C1 or cervical spine throughout anterior to posterior mobilization, really important for our clients.